Okay, my name's Herb Garrison. I'm a professor of emergency medicine emeritus at the ECU Brody School of Medicine and a senior officer with the ECU Health Foundation. I'm very fortunate to be here today with Dr. David Ryan, who's an addiction medicine specialist with East Carolina University, and we're going to let him tell us about the rest of his titles and backgrounds. And Dave, why don't we start with sort of where were you born and raised?
Oh gosh, yeah, sure. So I was actually born in New Jersey. I'm a third-generation Sicilian that grew up right outside of New York City.
And is it okay to ask what exit?
It is. Yeah. The answer is 164 off the Parkway.
164, there you go. But how did you make it to North Carolina? Tell us just a little bit about your background, because we want to get to the real topic.
Absolutely. So undergraduate in University of Florida, medical school at the University of Virginia, and then I was lucky enough, snuck in, something happened, and I was fortunate enough to end up at UNC Chapel Hill for my residency in OBGYN, which I graduated in 2011. The real prize was finding my wife, who agreed to marry me during residency, and she grew up in New Bern. And so after looking at a couple different places, we knew we wanted to come here to Eastern North Carolina, and that's been home ever since. We
were very fortunate to get you here in Greenville, and you spent a long time as a practicing obstetrician gynecologist. How long did you do that? Just talk about that for just a minute.
Yeah, I was in private practice here in Greenville for about 9 years. And I mean, I loved my group. I loved my partners. I mean, I really enjoyed the work that I did. I love being a part of people's lives in that way, seeing them through deliveries, through multiple children, through some of the sadness of maybe a miscarriage, through surgeries, like all phases of life. I just really loved caring for women across that spectrum. I just always felt particularly called to work with patients with substance use disorders, and I didn't know what that was supposed to look like or how that was going to look. And then really in about 2020, I kind of reached a point where I realized I needed to make a decision if I was going to continue doing what I'm doing, which did bring me a lot of joy, or if I was going to step out and in faith and see if there was something that I could do to see if this other passion that I had could be something I could practice or I could make a difference in.
The cool thing about medicine is you can actually have another career. So it's almost like you had a career as an obstetrician gynecologist, and now you have a career as an addiction medicine specialist.
I do, yes. And I'm also really happy I still continue to work with the Department of OBGYN. I do a half day a week of just general OBGYN clinic, which I still enjoy. And then the perinatal clinic, which I think we're going to talk about.
Yeah. So the main topic of today is substance use in pregnancy. Why don't we start with the woman that's pregnant and how something like substance use might come about?
Yeah, it is. It's an important topic, and I think when I talk about substance use in pregnancy, there are really three things that I think are really important to mention. Number one is that it's very common. It's oftentimes kind of shunned and hidden, and not something that people talk about. But when you look at the rates of substance use, and that includes things like nicotine, tobacco, cannabis, non-prescribed substances, or even alcohol, the use of these things is basically as prevalent as preeclampsia and diabetes. And so it's very common. Actually, 1 out of 7 women have used alcohol at some point in the pregnancy in the last month. So it's out there. And not every woman that uses a substance has a use disorder. But when use is occurring in a pregnancy, the risk of there being a use disorder or an addiction is a lot higher. It also is the risk of people trying to stop and then finding themselves unable to do so. The second thing is I think that it's important to understand that there's so much stigma. I mean, it really is. I mean, substance use disorder in and of itself carries a lot of stigma. People feel like it's a moral failing, it's a bad decision, that people should just do better, which we know biologically can't happen. When you have the disease of addiction, there are things that prevent an individual from stopping. And then when you put pregnancy on top of that, the stigma is just amplified. And it really, really creates a very difficult time for women to get access to, first of all, feel like they can be honest and then get access to care. And then the third thing I want to say is that when we're talking about substance use in pregnancy, that pregnancy is a very, very unique time. I mean, emotionally, mentally, physically, all of the things. And with the changes of pregnancy, oftentimes come different considerations, different barriers, different medication effects that need to be addressed. And it can sometimes be, if somebody is not familiar with the specific medications that we use to treat mental health or addiction, they might not know, oh, well, this needs to be adjusted, or this is how we need to watch out for this, or this is how we counsel somebody who's on these medications. And so really finding that comprehensive care can be really challenging.
So a couple things come to mind. One is you said 1 in 7 women have some sort of use during their pregnancy.
Yeah, 1 in 7 women have used alcohol in the preceding 30 days.
Yeah. So how does the use of substances in pregnancy compared to the non-pregnant population? What are the levels about the same?
Yeah, so it's really an interesting finding, and again, this is from data that's almost about 10 or 12 years old, because it is difficult to find accurate data. And so when we have it, even if it's old from like 2013, 2014, we tend to hang on to it. And what you find is actually when people are using substances, and when they learn that they are pregnant, if you follow the substance use during the trimesters of pregnancy, it actually drops. I mean, for everything, alcohol use, opioid use, tobacco, everything really continues to trend downwards as the pregnancy progresses. And I love mentioning this because what that tells me, when I hear that, what that tells me is that pregnancy is a time when people are excited to make a change. When maybe for the first time a woman has access to healthcare, or they have different things occurring in their lives, or they have a different, the pregnancy could be a reason for themselves to make a change, right? There's a lot of things and that motivate people at different times. And so what that tells me is that this is a population that is actually ready for an intervention. And unfortunately, sometimes what happens is that we seem to offer the least amount of resources to the population that would actually benefit the most, who is actually most likely to make the change.
And we're going to get there to the resources.
We are going to get there to
yes.
the resources, yes.
So are most of the women who have a substance use disorder when they're pregnant, did they have one when they came into the pregnancy already? Or because you hear about women who have cravings for things like pickles or a certain type of ice cream or something like that. Are there some women that develop a craving and that craving's met with a substance use, yet they didn't use substances before their pregnancy? Or is it most they're sort of predisposed, they were using substances already?
Yeah, gosh, that's a great question, because, I think it's important to point out that not everybody that uses a substance has a use disorder. And that's across the board. And I think we know that kind of intrinsically. Not everybody that has a beer watching football on Saturday has an alcohol problem.
Right.
And so sometimes what ends up happening is a woman is, just engaging in substance use, and there's not too many consequences from it. And then there's a pregnancy, and then they try to stop, and then they can't, either because they just find themselves unable to do so, or they've developed a physical dependence, and the withdrawal is so bad. And sometimes that's the first opportunity where it unmasks itself. The parsing it out of whether or not it develops in pregnancy, you're right. The way the physiology changes, it actually does affect cravings for different things. Like we can actually see the science and the receptors, and we think the hormones affect in different ways, which again can also help and can sometimes aid in the cessation of substances, but also can sometimes be a barrier, right? Can actually continue or worsen. And people who have been stable for 2 or 3 years can enter in a pregnancy, and it can actually become a very unstabilizing event and put them at risk of returning to use, which is another reason. If somebody is stable, it's not bound to happen, but it's another reason to say, hey, let's make sure you're getting really intentional, informed care to make sure everything continues to go well.
So we would want to help every person that has a substance use disorder, but in this situation, there's 2 people involved. You've got the pregnant woman and the going to be born soon baby. What are the risks for substance use in pregnancy? We hear about you shouldn't smoke, you shouldn't drink. Those are bad things to do anyway. But how does that pose a risk for the newborn?
Oh gosh, that's such a great question, and it's a sensitive topic too, because we are balancing the best outcome for the pregnancy, keeping the fetus and the soon-to-be baby in mind, but also acknowledging that a lot of times historically, substance use has been, and the consequences thereof have been overblown and have ultimately resulted in a lot of really tragic occurrences, like removing of children from the home when maybe that wasn't the best option, a lot of jail times. I mean, gosh, in some states, luckily not in North Carolina, but in some states, substance use is illegal in pregnancy. which might intrinsically, you might say, well, that's good, we're protecting the baby. But really what you do in that case is instead of getting people treatment, they hide it and then you put them in prison instead of a treatment program. So there's problems with that. The ultimate, the best case scenario would be, right, if a woman is pregnant and she exists in a bubble and eats organic food, right, and breathes clean air for
no
9
McDonald's,
months. Right,
no,
exactly. No McDonald's,
no salt.
no Oreos, things like that. Everything has risks. Oreos carry risks. And so I find it most helpful to inform my patients about what we know. So if there is alcohol use, my advice is going to be cessation. Why? Because we know with excessive alcohol exposure come a lot of problems that can be permanent. Cannabis use is a hot topic. There's a lot of mixed data about that. But it seems that any substance that could really affect the way the brain forms, the way the neurological connections form in the brain, potentially could have some outcomes that maybe aren't ideal. That's probably as much as we know. Opioids, interestingly enough, we don't think that non-prescribed opioid use or prescribed opioid use actually carries long-term effects. Same thing actually with stimulants. They can be risky for the baby during the pregnancy. Long-term, it doesn't actually look like there is. So it's hard to make a blanket statement regarding each substance. But what we want to do is provide the information, tell them what we know, and if finding out where the patient wants to go with it, and if their desire is abstinence, figuring out how to get them there.
So let's get to the woman who's going to be seeing her obstetrician gynecologist or her family physician. And how critical is screening, and how do you go about screening?
Mission critical. Could not be more critical. It is recommended by ACOG. I believe it's recommended by the AFP. Any professional organization that has anything to do with obstetrics or addiction says that we should be using validated screening tools. And what does that mean? A validated questionnaire. There are questionnaires that have been studied in pregnancy that can be given to patients where they answer questions regarding their history of substance use and their current substance use. And when those answers are positive, that results in a conversation and a discussion, and then a referral is indicated usually. So here, for example, at ECU Health, we use the 5 Ps. It asks about, partner use, past use, parent use, problematic use during pregnancy, things like that. And if you answer positive to some of those, well, then you have a further conversation. What it doesn't do is diagnose a substance use disorder, right? That has to be a conversation, and then finding out, what the person wants, and if they want assistance with tapering down or stopping, how to do that. It is not a urine toxicology test.
I was going to ask, is there a role for urine drug screening?
Oh, we could do. I could do an hour. I could do a whole podcast. I'm very passionate about this subject. So it is not a screening tool. It is completely inappropriate. I would even say probably borderline unethical to do a urine toxicology test on anyone, but especially a pregnant woman who doesn't know you're doing it. It is just, there's no reason to do that.
Well, it seems like just that would be a general principle, which is you want consent for everything you're going to do for a patient.
You do. You want consent, and you want informed consent.
Right.
And the big issue with pregnancy is because those tests are not great. There's a lot of false positives and a lot of false negatives, but they're treated as gold standard, definitive, 100%. Right. And then those results are taken, and oftentimes punitive things are done. People are forced into things, talked down to, referred out. DSS becomes involved, which again, I'm so grateful for our partners at DSS. They do really, really hard work, and sometimes they need to intervene, and sometimes that is the best thing for the mom, and I can't imagine how hard that position is. So when I say that, I don't want to speak pejoratively of them, because they work really hard. Pitt County DSS, by the way, that's a wonderful organization full of really wonderful people, but historically, it has led to maybe things and issues and cases that probably shouldn't have. So we don't want to do that. We can use it as indicated, and there's several indications for it, but always with consent and understanding it is not a screening tool for a substance use disorder.
I suspect we could do a whole podcast on substance use disorder and the genetic basis for it, and how it's not a lack of will.
Oh, yeah.
It is a disease and an illness, and That's the case in pregnancy as well.
Mm-hmm. It is. Yeah, there are, again, yes, you could, whenever I talk about addiction, I do always spend about 5 to 10 minutes explaining that, showing the neurobiology, explaining how the reward pathway gets hijacked by substances, how that on a very subconscious level starts guiding behaviors and steering behaviors. I think we can see it. I think there's just an obvious example of it. Like I've never had, when I would talk to a patient about smoking, I never had a patient, when I told them smoking was bad for them, I never had them look at me and say, Dr. Ryan, no one has ever told me that smoking is bad. Thank you so much for providing me with this information. I will now quit. Right? If I create an environment where they can be honest, they'll give me a whole reason why they want to stop smoking. They don't like it, it's expensive, they can't taste food, they're worried they're going to get cancer. They'll give you a whole bunch of reasons why they want to stop. And I believe it, I think they do. But then when push comes to shove, they can't.
Yeah.
It's because of that neurobiological mechanism.
Addictive. Yeah.
It's so addictive.
Yeah.
It's outside of their conscious level of control.
So you have a woman in your clinic, screens positive on the survey.
Mm-hmm.
What are we doing for women here in Pitt County and Eastern North Carolina to help with this situation?
Yeah, it's so exciting. So I had the opportunity, with the support of both Dr. Lang with psychiatry and Dr. Whiteside with OBGYN, to open ECU Impact, which stands for Integrated Model of Perinatal Addiction Care and Treatment. It's our region's first and only integrated perinatal addiction program, and one of 6 in the entire state of North Carolina. Wow. So it's really exciting. And what we do is, at the Brody School of Medicine, we offer addiction care and obstetric care at the same time, at the same location. And the way I describe it to patients and providers is that we provide addiction care that's obstetric informed and obstetric care that's addiction informed.
Wow.
In a patient-centered, evidence-based, stigma-free way.
If a physician is, let's say a primary care physician, finds that one of their patients is pregnant, they do a screening, they find that they may have a substance use disorder or trending more in the direction of using substances during their pregnancy, how would they get into your clinic?
Yeah, absolutely. We tried to make this as simple as possible, and I think we've succeeded. If they're an EPIC, right, an ECU health provider, it's one order, an ambulatory referral to addiction medicine. And in that, you can check 2 boxes: addiction medicine, which goes to our general addiction clinic, and perinatal addiction. And so if you're pregnant, your perinatal goes right to ECU Impact. If you are a provider who's using the referral form, the fax form, there's a box on there literally that says ECU Impact, perinatal addiction, and you check it. And all I really need is, I need you to do 1 or 2 of those things and just make sure that the patient's phone number is accurate, because that's one of our biggest barriers is contact information, getting patients to pick up the phone. I will say I think it's also really useful to talk to the patient, to let them know, hey, this is what we found, this is what it would indicate. Would you be interested in a referral to this clinic? Maybe a one-time consult, maybe transferring their care. But oftentimes I think women are understandably so very frightened about admitting that there's an issue and then going to a place that's dedicated to that issue. And so getting them in the door is hard. Once we get them in the door, I think that we provide care in a way that they enjoy and feel comfortable with. Because we have a pretty good, once we get them there, we have a pretty good rate of people continuing to see us.
And do y'all follow them through the pregnancy and deliver them? Or let me put the question another way. If a woman said, I'd really like to go to that clinic and I'd like to see those docs and nurses and people, but I'd also like my OBGYN to deliver me, how does all that work?
Sure, I would love to co-manage, right? Because I understand, look, I was an OBGYN and I had patients that I was very attached to, and I like to think I had some patients that were attached to me. And so if they really kind of want to hold on to their provider, I mean, we have a model. I can meet once a trimester. We can do a one-time consult. With a signed release, I can communicate with that provider. And I'm very interested in just figuring out what's going to work best for the patient.
Are y'all busy?
We're getting there. Yeah, we're pretty booked 2 weeks out. And so, the Wednesday and then the upcoming Wednesday, we're full. And then, so we're getting to the point where we're thinking about adding another half day, and so, which is exciting because I want to make this as available as possible. I think people are starting to find out about us. I think they're starting to refer a little bit more. And so it's an exciting thing to be able to offer.
How are you doing? How are your outcomes?
So I got the level D anecdotal evidence. We are figuring out a way because we're coming up on a year, and we do need to figure out how to formalize this. I feel very proud of the work that our team is doing. I can think of several patients off the top of my head who I know received care that was really top notch through our clinic. I can think of several patients who I really think that because they were able to see us, because of all the things that we have to offer, we were able to get them started on not only substance use medication but mental health medication, right? Because there's so much overlap there, and we're able to manage that and get people on that. And I know that that's going to improve outcomes. And so what's been great too is that I've gotten to hold on to a few patients. They've delivered, they're postpartum, and they've wanted to continue their care with us. So we've transitioned them over to ECU addictions. So it's been exciting to see how we've been doing.
Well, so on behalf of Eastern North Carolina, thank you. Thank you for, well, tell your wife thank you for making sure you got here. And from New Jersey, and thank you for all you're doing to help with addiction and addiction medicine here in Eastern North Carolina. We're glad you're here, and thanks for
appreciate that
for being one of our docs.
You're very kind. I appreciate that. It's great to come here and share that.
I'm Herb Garrison. Been here with Dr. David Ryan. He's running the ECU Impact Perinatal Program, doing great work. Thank you very much.
Are you struggling with mental health or substance use? You're not alone, and help is just a click away. The Substance Abuse and Mental Health Services Administration, or SAMHSA, connects individuals and families to trusted treatment, support, and recovery resources. From crisis lines to community programs, SAMHSA empowers people to take control of their mental wellness. Visit samhsa.gov today and discover the tools that can make a real difference. Because recovery is possible and support is here. It's just a mouse click away. That's samhsa.gov. Remember, you are not alone.